understanding and managing heart failure with preserved ejection fraction, what I will be calling HFpEF. Good morning and welcome. One of the most common questions many of you have asked in this series is, how do we manage heart failure with preserved ejection fraction, and do the 4 pillars of heart failure treatment apply? The short answer is yes, but HFpEF requires a different emphasis with a strong focus on comorbidities and cardiometabolic care. So today I want to talk about heart failure with preserved ejection fraction, HFpEF. Imagine this: your heart pumps normally, yet it struggles. You feel breathless, fatigued, getting tired easily, even when your ejection fraction is normal. That is HFpEF. It's a condition that is common and serious and deadly if missed. HFpEF is a form of heart failure in which the heart's pumping strength is normal. Ejection fraction is over 50%, but the heart muscle is stiff and does not relax properly. Because it does not relax properly, it cannot fill well with blood. The pressure rises inside the heart, causing congestion, and patients experience the classical symptoms of heart failure, such as breathlessness, fatigue, poor exercise tolerance, leg swelling, despite a normal ejection fraction. So let's start with what the guidelines clearly state. HFpEF accounts for about 50% of all heart failure cases. So it is common, and its prevalence continues to rise worldwide. And most of the time it's missed because the EF is normal. It predominantly affects older adults. It's more common in females, and it is strongly associated with underlying comorbidities like hypertension, diabetes, obesity, atrial fibrillation, coronary artery disease, and chronic kidney disease and sleep apnea, which I covered earlier. Symptoms commonly include shortness of breath, fatigue, leg swelling, reduced exercise capacity, fatigue. And here is the critical message that is often missed. HFpEF is not a milder form of heart failure. According to the guidelines, the ESC, the American ACC guidelines, all-cause mortality for HFpEF is comparable to heart failure with reduced ejection fraction, especially early areas after diagnosis. Hospitalization rates are also equally high. Deaths frequently result from cardiovascular causes and also comorbidity-related complications. So HFpEF is not milder. So remember this clearly. A normal ejection fraction does not mean a better prognosis. Preserved EF does not equal to preserved survival. It carries equal mortality to HFrEF. How do we diagnose heart failure with preserved ejection fraction? Diagnosis requires all of the following. Number 1, symptoms of heart failure, such as breathlessness, fatigue, fluid retention. Number 2, preserved ejection fraction on echocardiogram. The EF should be over 50% or higher on echo. Preserved ejection fraction. 3, objective evidence of cardiac dysfunction. This includes diastolic dysfunction, left atrial enlargement, left ventricular hypertrophy, or elevated feeding pressures. All those are also picked on echo. And number 4, elevated natriuretic peptides. So your BNP or NT-proBNP should be elevated. Please note the levels may be lower in people with obesity. And finally, other potential causes of heart failure are excluded, like valve disease. So once the diagnosis is made, how do we manage HFpEF, and where do the 4 pillars fit in? HFpEF has no single curative drug. Management focuses on prognosis, symptom relief, and aggressive treatment of comorbidities. HFpEF is a systemic cardiometabolic syndrome. So treatment of comorbidities is not just supportive, it is disease modifying in heart failure with preserved ejection fraction. So what are the core principles? Treat the congestion and treat the comorbidities. That is the foundational. Control your blood pressure, manage atrial fibrillation, optimize cardiometabolic health, obesity, reduce hospitalization, and improve quality of life. So what of the 4 pillars are central to HFpEF? The main pillar by guidelines is SGLT2 inhibitors, sodium glucagon-like cotransporter 2 inhibitors such as dapagliflozin, empagliflozin. Those are foundational therapy in HFpEF, and they carry a class 1 level A recommendation from the guidelines. So for HFpEF, number 1 is your SGLT2 inhibitors. They reduce heart failure hospitalization, they reduce cardiovascular death, they improve symptoms, and work whether the patient has diabetes or not. Number 2 drugs are diuretics. These remain essential for symptom control. They relieve congestion, breathlessness, edema, but they do not reduce mortality. So diuretics for symptom relief, especially fluid overload. The key thing, number 3 in HFpEF, is treat comorbidities. HFpEF is a cardiometabolic disease. Treating comorbidities is the key pillar in HFpEF. So for those with hypertension, which is a common cause of heart failure with preserved ejection fraction, your ACEs, your ARBs, your ANIs, or beta blockers control the BP. For diabetes, optimize glycemic control using your SGLT2 inhibitors and GLP-1 receptor agonists. I'll discuss about those slightly later. For obesity, lifestyle-based weight loss and GLP-1 receptor agonists, which will improve symptoms and exercise capacity and also cardiometabolic risk. For those with atrial fibrillation, treat the atrial fibrillation, whether rate or rhythm control, and remember anticoagulation. We discussed this earlier in the series. For coronary artery disease, use your anti-ischemic, optimize lipid control, and your antiplatelet therapy. And for those with sleep apnea, CPAP. We covered sleep apnea in an earlier episode. So CPAP to improve oxygenation, blood pressure, and cardiac workload. And also for CKD, the pillars for management of chronic kidney disease, close monitoring, and also drug titration to avoid the side effects. A special mention of the GLP-1 receptor agonists. Glucagon-like peptide 1 receptor agonists, GLP-1, are also very key in HFpEF. Glucagon-like peptide 1 receptor agonists, an example are the semaglutide, liraglutide, dulaglutide. They are cardiometabolic therapies and not just glucose-lowering drugs. So in HFpEF, they treat obesity and insulin resistance. They promote weight loss, and they improve blood pressure, lipid profile, and glycemic control. So remember, GLP-1 receptor agonists, they reduce cardiac workload, and they lower major adverse cardiovascular events in trials. So GLP-1 have a role in HFpEF for those who are obese, who have diabetes, in addition to the SGLT2 inhibitors. So they are increasingly recognized as an important adjunct therapy in selected patients with HFpEF, especially those with obesity and diabetes. We said HFpEF is a cardiometabolic disease. So a guideline snapshot for the treatment for HFpEF. Number 1, SGLT2 inhibitors, class 1, level A. They should be used in everyone with HFpEF. Your diuretics, they are also class 1 evidence for patients with fluid overload. Your ACEs, ARBs, and MRA beta blockers are class 2. Evidence is not as strong as SGLT2. And finally, lifestyle and comorbidity management is foundational for HFpEF. So the heart of the matter in HFpEF carries a high mortality compared to HFrEF, but it is treatable. Put your SGLT2, GLP-1s for obesity and diabetes. Lifestyle and comorbidity management can reduce mortality. They can improve survival and reduce hospitalization and preserve functional capacity. So HFpEF is serious but manageable. Dr. Beatrice Muthui-Mutua, saving lives one heart at a time.